Okay, welcome everyone. I'm Julie Bettinger. I'm a professor at the Vaccine Evaluation Center at BC Children's Hospital and UBC, and I'm joining you from the traditional and unceded territories of the Coast Salish peoples. It's my pleasure to welcome you and our presenters to the fourth session titled Racial Equity in Immunization. This session features presentations followed by 15 minutes of discussion with the panel till we go to break at 3 o'clock. The discussion section will be moderated by Rebecca Haber, immunization leader from Fraser Health. So I encourage you to submit your questions to Slido throughout the presentations. We'll be taking all questions after all the speakers have presented. And if you see any questions already in place there, just upvote them and we'll be sure to answer them. So to start us off today, I have a brief presentation, which I'll go ahead and share. Hopefully this works. So maybe let me know if you can't see it. So I have a brief presentation just to orient everyone in the audience to the topic that we'll be speaking on. I think we've all likely heard and used some of the definitions I'm going to provide, but I thought it would be very helpful for us all to sort of approach it from a common place. So first off, oh, sorry, I just hit the wrong thing. First off, race is a term I think that we all have heard of, and this refers to the categories into which society places individuals on the basis of physical characteristics. So this would be hair color, hair type, facial form, eye shape. And it's a classification system that's been created for social and political reasons. I think that's an important thing to recognize. Racism is the belief that a group of people are inferior based on the color of their skin or due to the inferiority of their culture or spirituality. It leads to discriminatory behaviors or policies that oppress, ignore, or treat racialized groups as less than non-racialized groups. Equity requires the creation of opportunities for historically, persistently, or systematically marginalized populations to have equitable access to immunization programs. Cultural safety is a term I'm sure many of us in the audience are familiar with, but I don't know how many of us could actually define it. And what this means is an outcome based on respectful engagement that recognizes and strives to address power imbalances inherent in the healthcare system. It results in an environment free of racism and discrimination where people feel safe to receive healthcare. And finally, the term I'd like to end with is intersectionality. And this term was created about 30 years ago by Kimberly Crenshaw to describe sort of the interrelation of a lot of different of these factors. So it's a lens or a prism for seeing the way in which various forms of inequality often operate together and exacerbate each other. I have my training in epidemiology. So for those of you that approach things in this way, you could sort of think of it as, instead of being an additive effect, it would be a multiplicative effect. So just because you have two things together, sometimes when you combine them, it's an even larger effect. And that's what intersectionality is really talking about here. And what we often miss when we talk about these things is that how some people are subject to all of these things, and the experience is not just the additive or the sum of its part. It's really more of a multiplicative effect. And then I'd like to end here with the wheel of power of privilege. And this was created by Sylvia Duckworth. And I think it really nicely kind of puts this into a visual image. And, you know, I would like each of you to kind of look at the different pies in this wheel, with power being here in the center of the wheel and marginalized being out here on the outside, and sort of think about where you would place yourself on this wheel. So if I look at it, for me, I'm a white post-secondary researcher, so very close to the center of power on this wheel. So where are you situated? What category, where do you fit on this power wheel? And I think even more importantly, where are the communities or the individuals that you work with situated? So without further ado, I would like to introduce our speakers and move on to the wonderful presentations that we have organized for this afternoon. So with our common language defined, we'll begin the session with Stephanie Allen from the Hogan's Alley Society, and she'll be presenting data from a study examining vaccine attitudes in BC's Black community. She'll be followed by Gurvir Dhutt from the Vaccine Evaluation Center, who will be presenting data from a study with the South Asian community in the Lower Mainland. He'll be followed by Samantha Tong, who's the manager for the South Asian Health, tripping over my words, South Asian Health Institute, who will speak about vaccine delivery with South Asian communities. And then finally, Marion Guenther from the First Nations Health Authority will describe immunization delivery approaches taken with First Nations communities in BC. Their short biographical paragraphs are found in the program for today's session, and you can find this on the BCCDC website. So please enjoy the sessions and the presentations, and ask any of your questions on Slido for Rebecca to put up to the panel at the end of the sessions. So without further ado, I'll hand it over to Stephanie. Thank you.
Good afternoon, everyone. I'm just going to share my screen if you bear with me for a moment. Hope that's looking good for everyone. A real pleasure to speak to you today, and an unusual forum for me to be at, but I'm really pleased to be here and share with you the findings of our survey of Black communities.
Stephanie, we can see, you might want to change the view. It's showing up as, we can see the speaker's view, not the presentation view. Yep, perfect. Looks great.
Thank you. Yeah, I'm trying to do, okay. So thank you so much for this opportunity. Really grateful for the chance to speak to you all today. I'm speaking today from the unceded, ancestral, and unsurrendered lands of the Musqueam, Squamish, and Tsleil-Waututh peoples. And I recognize that as a descendant of enslaved people, it's critical for my work to be done in solidarity with Indigenous peoples on these lands. So yes, as I'm saying, we're speaking today about a survey that was funded by the BC Immunization Committee to understand the vaccine intentions among Black communities in British Columbia. As far as my disclosure, I'm with the Hogan's Alley Society. I'm a board member there, unpaid. We did have a financial sponsorship for this survey, but I was an unpaid board member overseeing the work. And of course, there were no other we provided in-kind support, and this doesn't pose any conflict of interest for the data I'm about to share. There was no potential bias, but you know, we'll leave that to others to decide. When we talk about racism, sometimes folks think racialized people are biased when they talk about it. So a little bit about my presentation today. I'll give you an overview of why we did this research, the methods that we did to recruit folks. They really focus in on the key findings and our recommendations for moving forward. So in the early months of the pandemic, back in 2020, Black community organizers met with leaders in the province to ask about COVID-19's impact on Black communities in BC. We know from the social determinants of health that the socioeconomic places that people of African descent find themselves in are often going to be impacted most negatively by those factors. And it was acknowledged at time by leadership that disaggregated health data was not collected or reported in British Columbia. Now, we saw as the pandemic progressed the impacts on other Black communities that were being reported, which definitely emphasized and validated our fears for Black communities in BC. We decided to get to work to address that gap. To address that gap, we hosted the BC Black Healthcare Matters conversation with Black healthcare practitioners in April of 2021. This was specifically because we wanted to speak to Black community members with Black healthcare professionals about what we started to see emerge in our communities, which was hesitancy around the vaccine. And I want to be really distinct. This is not anti-vax behavior, but this is people that are scared, apprehensive for a number of reasons we'll get into. And so we thought this forum was a way for folks to get healthcare advice, to hear about the truth about vaccines, to address the fears that they were seeing on social media right from Black healthcare providers, so that they could kind of have that information without the filter of racism that so many have experienced in healthcare settings. And we also did this because we know in our families, people that we love and hold dear are absolutely hesitant when it comes to vaccines. This is my Auntie P. She lives in Montreal, and before there, cake making shows were all over the Food Network, she was one of the best I've ever seen. She's made every wedding cake in our family in this country, and we have a very big family, and she's really one of my favorites. And when it came to our conversations about the vaccine, my aunt was very clear. Her experiences of racism in this country made her extremely hesitant. She looked at the deadly impacts of the pandemic, and she looked at her experiences, and she chose to be unvaccinated, taking her risks with a virus instead of what she called white people's medicine. Now, we got to work on our survey later last year with the collaboration of Dr. Gina Ogilvie, who was featured in our Black Healthcare Matters panel, and with the support of the BC Immunization Committee. So in October, we decided to launch this survey after some collaboration. And we promoted the survey through our social media platforms. Hogan's Alley Society is a nationally recognized not-for-profit organization that is led by people of African descent. And so we have a pretty robust tens of thousands of followers across all of our social media platforms. We promoted the survey there. We linked with other Black organizations in the province. The Interior Health Authority shared information on our survey, which was really beneficial. We also went to Black-owned convenience stores and other places posting posters, and we had some great media coverage from CBC, the Georgia Straight, and the Vancouver Sun. Now, just getting into some of the key findings of the survey then. So this story of our survey really tells the story of Black respondents, not really all Black people in BC. We had 303 respondents that identified as Black people between the October and launch and February 11th kind of inquiry that we made for this presentation. Of course, there's over 40,000 Black people in BC, so we can't say that we're telling a story of all Black people. And then we look at the characteristics of those who did respond. We found that a lot of them were more educated, 65% having a bachelor's degree. 72% were women or non-binary identified people. They were predominantly younger, between 25 and 44. They were either employed or students. And that 2/3 of them made over $50,000 per year. We understand that a third making below that is actually a good success rate in surveys like this, because oftentimes harder to catch folks in surveys like this. So that does tell us something about the survey population as far as the responses. Our preliminary findings have been that 95% of the folks received a COVID vaccine, 4% had not, and 1% were ineligible. Of those who had received the first dose, 92% received the second dose, 6% reporting being ineligible, and 2% saying that they haven't received it yet. So, start to do some deeper digging on that one. 78% intend to receive the booster dose, while 22% reported that they did not intend to. And when we looked at some of the reasons cited, some people said that their healthcare professionals said it might not be necessary. Other folks reported that they thought they might have enough immunity with the first 2 doses, or started to feel more weary about taking a third dose. And of the respondents who are yet to be vaccinated, 83% said they were unlikely to receive a vaccine in the future, which is quite considerable when you think about the fact that the news and the headlines and the impacts of the pandemic are definitely demonstrating that Black people had higher risks. And so even with all of that, and considering the timeline of our survey, folks were still unlikely to receive the dosage, to be vaccinated. And of the respondents who had 1 dose, 50% are unlikely, they said, to receive a second dose in the future. And so, the reasons that folks gave for not being vaccinated, we've broken out here. We see people worried about the side effects, folks thinking that their bodies can fight off COVID, that the vaccine is not effective, that the vaccine was developed too quickly, and people being, a smaller minority of folks saying that they do not trust the government. And now, even though we had a high response rate of folks that did take the vaccine, I think what we're talking to you about is from a perspective of race equity. And race equity says you look at the minority and you understand the impacts of minorities. That's the way we have to take this analysis. So while folks might find that this survey population had a good response towards vaccines, I think what we understand is we have to dig deeper and understand the needs of the minority, because we don't want to see anybody in our communities left behind. Now, 98 of the respondents said they have kids aged 5 to 12. And of those, 34% said that they were unlikely to get their children vaccinated. And so some of the reasons why we know are varied. These are personal decisions, but I think it reflects an area of deeper inquiry as well. Oh, I'm going the wrong way, sorry. And then when it comes to this slide, we're just looking at, sorry, I've got family members who declined the vaccine. 39% of the respondents, we added this question just in January because we knew that there were folks that were responding to us that had a higher likelihood of taking the vaccine, but we wanted to understand, do people have family members, and did family members influence your decision? So we added this question and found that 39% of the folks who did answer this question said that they have family members who have declined the vaccine, but it did not affect their decision to be vaccinated. In looking at the comparative analysis, which I think is quite, important for this study, we see analyzing our data that similar findings across age groups are found, but lower in the ages 35 to 44 years old as far as their vaccination rates. It was lower in those who identify as men. It was lower in respondents who have an educational level below college. It was lower in respondents who had COVID-19 previously. And it was similar across income groups, higher in those who regularly received a flu shot, and higher for those residing in the city of Vancouver compared to those living in other parts of Metro Vancouver. And when we look at Black population distribution, we know that in Vancouver proper, there are less Black people in the population than we find in Surrey and some of the other areas. Now, moving forward, we as Hogan's Alley Society are dedicated to continuing research with this cohort and to leverage the strength of this collaboration. I think this was a phenomenal experience. We had a number of fantastic co-investigators. This is a first for our organization, but obviously something we know is a need in our communities. We also want to conduct deeper analysis of the survey data collected with further comparative analysis and hopefully publish in the future. But very importantly is to speak to many of the authority figures that I just saw on the last panel, and to people who are making policy, and very importantly to Black communities, because we want to make the case for policy change. And what is that? Our recommendations for moving forward are that we have to acknowledge the need for and develop trust among Black communities in BC. We have to understand and measure the lasting impacts of racism as a critical social determinant of health, both the interpersonal, the structural, and the systemic, all of which are showing up and existing within our healthcare systems. We have to commit to working with community-based groups in the collection, analysis, and reporting of disaggregated race-based health data. And Hogan's Alley Society is absolutely ready and positioned to do more work in this area. I think it's also critical for everyone to think about how to evolve vaccine delivery plans to meet the needs of Black community members across BC. Especially those who remain just untrusting of the system or unwilling to see vaccines as important to their well-being. And we have to establish a fund and fund a permanent Black health research body that can implement systemic disaggregated data collection, reporting, and informing policy on BC's Black communities. Now, my auntie that I introduced you all earlier contacted COVID shortly after New Year's Eve, after she helped me with my own wedding and to make my own wedding cake from afar. And unfortunately, my aunt died as a result of COVID and the implications and the impacts that she got on January 20th. So this is very dear and very personal to us. These are the faces of the statistics that you all have witnessed today and that you see in your work. We don't want to lose any more of our loved ones. We don't want to lose any more people to preventable and avoidable illness because they have experienced so much racism. So I want to thank you for the time. I look forward to hearing from all of you who want to partner with communities like ours, community groups like ours, to address these very grave concerns. I thank you for your time.
Sure. Thank you. Thank you, Stephanie, and thank you for sharing your story with us and those really important findings. We're going to pass it right over to Gurvir so that we can move along with the program. Thanks.
Good afternoon, everyone. Thank you for having me today. And thank you, Stephanie, for your presentation. I want to acknowledge that I am presenting today from the traditional, ancestral, and unceded territory of the Musqueam First Nation. My presentation today will be on South Asian community member experiences and feedback for improving COVID-19 vaccine-related communication. Before I begin, I also want to acknowledge that this program has received financial support from the Michael Smith Foundation for Health Research and Genome BC, and I declare no conflict of interest. The South Asian community member experiences and feedback that I will be presenting today were collected as a part of the COVID-19 community response study being conducted at the Vaccine Evaluation Center. The purpose of the study is to identify the information needs, values, beliefs, and experiences related to COVID-19 vaccination among the Lower Mainland South Asian community. The goal of the study is to guide future communication efforts for the COVID-19 and other vaccine-related programs. The results from this qualitative study that I will be presenting today are informed by 41 South Asian community members interviewed between July 24th and October 29th of last year. The ages of the community members interviewed range from 18 to 65 plus. 58% were females, 13 were born in Canada, 27 in Asia, and 1 in Europe. As mentioned on the screen there, most had 2 doses of a COVID-19 vaccine. However, none were unvaccinated. We are pleased to share early results from our study with key recommendations for public health immunization programs, with the first key recommendation being to avoid conflicting messaging within public health communications. This is because conflicting messaging impacts the trust and confidence people have in public health communications. One of the examples shared during our interviews had to do with mixing different vaccine doses being recommended, only later on to be considered inadequate for travel. This caused a lot of individuals in the community to lose trust in public health. As a result, it is imperative to avoid delivering conflicting messages and ensure messaging is consistent across different media platforms and public health groups. Several of our participants also mentioned that having multiple different sources of COVID-19 related information made it difficult for them to judge the credibility of these sources. They suggested having one source of information, which is shared on different platforms. The second key recommendation, as suggested by our participants, is to address common information needs in a timely manner. Some of the South Asian community's information needs surrounded the effectiveness, safety, purpose, and science behind the vaccine, the impact of the vaccine on fertility, the impact of the vaccine on pre-existing medical conditions and allergies, and lastly, the impact of mixing vaccines. The third recommendation is to include people's direct emotions, feelings, stories, and experiences with COVID-19 vaccination and infection in public health communications. This is because individuals consider these experiences as being more trustworthy and would prefer this over scientific data and statistical numbers. The fourth recommendation is to ensure messaging is sensitive to the community's beliefs and culture. Our participants stressed the importance of considering not just what is communicated, but also how. Strategies to make messaging more culturally sensitive include communicating in culturally appropriate settings, such as places of worship, with the involvement and support of community leaders and religious leaders. It is also important to ensure that spokespeople are from the community or look like community members. Language barriers were the most common structural barriers faced by the community in accessing COVID-19 related information. Our participants stressed the importance of communicating more than just the bare minimum in languages other than English. Moreover, our participants valued in-person and direct communication in addition to digital and print mediums. One participant suggested employing the help of international students from India who are well educated and equipped with the language skills necessary to communicate with the South Asian community. The fifth recommendation is to communicate in a simple language. As we all know, jargon and scientific language can be confusing, and this is especially true for the immigrant population. Therefore, it is important to communicate using language that is simple and easy to understand. The sixth recommendation is to be transparent in public health communications. Some community members found it difficult to understand the reasoning behind and implications of public health related restrictions and guidelines. They suggested providing rationale behind every guideline and restriction, as well as outlining how they implicate community members individually and within their specific community group. Our participants also provided some feedback on improving social media related communications. They suggested using simple, visually appealing, and easily digestible social media posts, and directly sharing these posts in social media groups such as WhatsApp broadcast channels. They also suggested using dedicated and regulated pages on social media to disseminate public health communications. Our participants also suggested posting YouTube videos in different languages and cultural contexts, just based on the number of community members that use YouTube. The last recommendation for today is to use appropriate communication mediums when communicating with the South Asian community. Some appropriate communication mediums include popular Punjabi TV channels, text messages, physical mail, and email. Radio was mentioned as being the most commonly used communication medium within the community, especially among the older demographic. Examples of popular radio stations within the community included 93.1 Red FM, 1550 AM, and 600 AM Sherry Punjab. Examples of appropriate communication spokespeople included radio hosts, cultural celebrities, well-known community members, and caregivers. Places of worship such as gurdwaras were commonly suggested as being appropriate communication venues, just given the number of individuals that frequent places of worship within this community. Places of worship were also defined as being a place where community members felt the most comfortable because they were surrounded by individuals who were similar and spoke the same language as them. Similarly, South Asian businesses were described as being appropriate communication venues. The results that I have shared today are also available on the Vaccine Evaluation Center website on the research page under COVID-19 research. I have also put the link on this slide for those who are interested in viewing this document. And with that, I want to thank everyone for listening to my presentation today. I will be happy to answer any questions during the question period at the end of the hour or through my email, which I have put on the slide. And now I will hand it over to Samantha for her presentation.
Thanks, Gurvir. I'm going to share my screen. Hopefully you can all see it. Just please let me know if you don't. Okay. So I am here representing the work that South Asian Health Institute from Frizz Health has done in relation to the COVID-19 vaccine delivery for the South Asian community living within the Frizz Health region. Before I start, just want to say I have no conflict of interest to disclose, and that I acknowledge Frizz Health provides services within the unceded and traditional lands of the Coast Salish and the Itlakatlan nations. And here's how I'm going to hopefully be able to approach sharing some of the work that we've done and our lessons learned and the successes and continued work. A little bit over just providing an overview of the context, the barriers, the facilitators, and our role during the pandemic, and some acknowledgements. Over 75% of BC's South Asian population lives within the Frizz Health region, and the South Asian Health Institute was created in 2013 recognizing that in terms of looking at the data, some certain chronic diseases were more prevalent amongst the South Asian community, and there was a need. So that was the impetus to really start the work. And really, SAHI used to advance the key health understandings of the key health issues affecting the South Asian population, but also to support the development of culturally relevant, evidence-informed strategies for improving the health of the diverse South Asian community within Fraser Health. And early on in the pandemic, this is not just unique to South Asian community, but just across the board, what we had seen in the data is that there was a high disease burden amongst racialized groups where there was like a large multi-generational household or where living situations were overcrowded. And there were large workplace outbreaks, if you may recall, in terms of at food and meat processing plants involving workers from diverse racial backgrounds. And the pandemic has really highlighted and amplified all the existing inequities that existed prior to the pandemic and just made it much more in our face, if you will. And so this has really resulted in the gaps in our ability to provide culturally appropriate messaging, language services, and effective ways of engaging with impacted communities. And then ultimately, impacting on the case and conduct management work, the effectiveness of the broad public health measures. And so here are some barriers and facilitators from the South Asian perspective. I just want to say that, a lot of what I've shared here is actually applicable to other communities and also beyond, like, the COVID-19 pandemic. At the individual level, as mentioned by Stephanie, there's a lot of fear and anxiety amongst the South Asian community members. There's low health literacy levels for some, transportation issues, mobility issues. And this was a big one here, the technological and digital literacy and access. We came across many members who had challenges. They didn't have a mobile phone, they didn't have an email address, and they weren't familiar with navigating or the technology or moving around, navigating the internet. A lot of vaccine hesitancy for some of the reasons that were identified earlier, a lack of the trust in the health system. And I think it's important to highlight too, because when newcomers or people come and live in our region, there's assumptions made, but sometimes we forget about recognizing where did they come from, what were their experiences prior to, and also what are the current experiences within our current health system. A lot of system navigation issues, language, as has been mentioned, and immigration status concerns. And actually, this was something new for us as we were doing our work, recognizing that a lot of people didn't feel comfortable going forward to get their vaccine because they felt that if they got their vaccine, it would impact their immigration status. For example, if they're applying for permanent residency, but also we had come across and worked with undocumented workers, and they didn't want to be identified. At the community level, associated with stigma COVID was associated with stigma quite a bit, and I think this was common across other communities as well. And kind of linking to what Gurvir said earlier is just the overwhelming amount of information around COVID that was just present, but also conflicting at the same time, from where people came from originally compared to what's happening locally or even happening across different provinces. And another thing that also we had found in our work is just the influence of global trends. And so we noticed early on in the pandemic, a lot of community members we interfaced with actually referred back to what was happening back in their home countries, for example, in India. And so I would say this is a barrier, but also at the time, but also later on, depending on the trends of what happened in India, is actually a facilitator for us here locally. I'll expand on that a little bit more. At the system level, we all, I want to say the royal we for now, all work in the health system, but it's designed for English speakers. And so there's a lot of assumptions that we make about the health-seeking behaviors, information access of people in general, and also of just different community groups. And as a result, we have unmet needs for the diverse communities, for example, lack of the culturally relevant information and messaging in the languages that are needed in various formats. We heard loud and clear from our community members needing to have that diversity because there's different health literacy levels and just the preferences of how people tend to prefer to get their information. And another barrier is just the lack of accessible, available, appropriate services and safe spaces. Not to say there aren't any, but just in terms of the availability of them, whether some of them are accessible in terms of are appropriate, it varies across the board. Again, that the assumption with our current health system is that Our current model and spaces are the AAA, which is the accessibility, availability, and appropriate services. Another barrier, what we have found is just the lack of paid time to get the vaccine. There's a financial impact when somebody working in a low-income job needs to make a decision: do I take time off and not get paid for it to get my vaccine, or do I continue to work because I have other bills to pay? I mean, thankfully, in terms of the provincial government being able to move forward and provided some paid time to get people to get the vaccine. It was still, in terms of the rollout and implementation, not everybody knew about it. And so they didn't really know how to access or what to do, or the employees weren't necessarily implementing it. And from a staff perspective, there's competing priorities, but also recognition that there's a need for awareness and professional competency for providing the culturally safe care that's needed. So it's all these ongoing things in the context of all this. Some of the facilitators for the South Asian Health Institute is that prior to the pandemic, we actually were able to, develop partnerships that we carried through into the pandemic, and that actually built a foundation for us to continue to build new relationships as we move forward. And so, to give an example, prior to the pandemic, we had about 11 partnerships with different places of worship, mostly of the Sikh and the Hindu faith, but since the pandemic, we have now expanded our community outreach locations to 56. This includes the places of worships, including the places of worship for masjids and mosques, for the Islamic faith, for businesses, shopping plazas, grocery stores, as well as other businesses as well. And so these are areas where we are focusing on where a high proportion of the South Asian community frequents, so that we can actually do our work there related to COVID-19. And strength that we have also is my team members are from the diverse South Asian community with fluency in different languages, and also have the understanding of the cultural context, which has helped us immensely in terms of being able to move the work forward. A strength of the community, I want to say community at large, but recognizing that there's diversity within the South Asian community, is that sense of the social responsibility to help community. And our partners, new and existing, were very supportive in sharing and promoting the COVID-19 relevant information to community members, and also very willing to host vaccination clinics for community. We had a lot of offers, but we weren't able to kind of meet all those offers. But one key piece too, and it's kind of linked to the trust piece, is that through our partners, our community members trust the community partners, such as the places of worship. And the community also has familiarity with locations of the clinics that we were working with our vaccine team on. So it helped to kind of facilitate the uptake of the vaccine amongst the South Asian community. And so just briefly over the role of SAHI, our primary role was really to engage with the diverse South Asian community, support them in safely, appropriately practicing COVID-19 safety and prevention, including vaccination, but also learning and understanding their needs of the community during the pandemic. And I would say because we've had our ears to the ground, connecting with the community, we've really heard what were the challenges, the issues, the concerns. And many of the things that Gurvir had shared earlier is what we have heard too. And we've seen the evolution of the issues that have come up depending on what was trending at that time, and now also to the boosters. And lastly, the advocacy, recognizing the different challenges experienced by the community. We advocate within our systems and also with our community partners and other systems. So for example, the navigation piece, we are hearing from community that they're having a problem, say, with the registration, through the provincial website. And so we explore a bit further about what was the issue or what was the challenge. And so it's because also just recognizing too that during the pandemic, many things were being new and things were being introduced, many things were being changed, adjusted as needed as we're learning. So I can understand how people were getting confused, but also needing that support. And so we were able to help advocate for a number of different things, including, working with our corporate communications team on ensuring that there was multiple languages available and all the different resources that were being created, so that it wasn't just limited to English or a few of the languages. Some of our work here is really around health literacy, education and awareness, knowledge translation from a cultural lens. For example, the provincial health orders, public health orders related to the pandemic and supporting our partners in understanding what it meant and how to implement it appropriately within their setting. The development and dissemination of culturally relevant resources, messaging, and campaigns. We did these in a number of different ways, and we targeted sometimes the big events, but we also aligned messaging depending on what was currently being promoted at the time. For example, it was testing or if it was vaccination, and we linked to all the messaging there. We provided consults to different teams within Fraser Health and also outside of Fraser Health. And system navigation support, kind of what I alluded to earlier, is just a lot of system navigation support, recognizing that, like say, even the VC vaccine card, it's set up in English, but people didn't, with language challenges in terms of not being able to speak English or be fluent in English, had challenges in terms of navigating the system. And outreach, which was a big part of our work, is really to link in with community, address their concerns, provide information, support them, and helping them navigate the system through in-person and cold calling in a number of different ways as well. And specifically to the vaccination part of COVID-19, we collaborated with our Fraser Health COVID-19 vaccine outreach team. And we delivered, in addition to the established community testing and immunization centers, these in-reach vaccination clinics, which were often one-off, planned in the community around community settings where the community frequented. And so SAHI really provided that planning and coordination support around the clinical logistics for supporting the clinical team, provided the immunization, everything from the front end of registering for with the provincial system to getting a temporary personal health number to the aftercare area and also being able to answer questions. We couldn't have done it without volunteers, and we had a number of different external volunteer groups in addition to our own volunteers help out with this in addition to staff. So the staff and volunteers at these clinics were able to speak a number of different South Asian languages. And I just want to make a comment too that while our focus was trying to make sure we supported uptake of the COVID-19 vaccination amongst the South Asian community, this was open to anybody in the community. And we did see the diversity of community members join. And so that was good to see. In partnership with our community partners, we delivered 29 in-reach vaccination clinics between end of April to mid-October. Like I mentioned, there's a high demand in terms of the vaccination clinics, but we were limited in terms of how much we could offer. So data that we collected and at different times. So from mid-May to October, we had supported about over 7,000 community members to be vaccinated. And in terms of first doses, this is data collected from mid-June to October last year, is just under 2,000, and probably more because we didn't collect the data at the early start as we're just starting to set up. Significant support was provided to community members for registration with the provincial COVID-19 vaccination system and for getting a temporary PHN. Sometimes at one clinic, we'd support over 50 people. And our clinics, we were there was scheduled to be a maximum capacity for about 400 doses. So that's quite a big number. And so we actually had quite a number of people come forward, hesitant at first, but recognizing and seeing other community members there getting their vaccine, they felt comfortable coming forward. And we had staff who could speak their language and support them in getting their registration, getting the temporary PHN, and then getting the vaccine. Through these clinics, we have been successful in being able to reduce a number of the barriers for community members in terms of language, in terms of transportation. And transportation, because we were holding these at community settings where community members are already familiar with. So for example, if a South Asian senior didn't know how to navigate or go to a different location, like a testing or immunization center, they knew how to get to their place of worship. So they didn't have any issues there and didn't need to rely on family to take them to where they needed to be. As mentioned earlier, the technological and digital barriers, even though the provincial line had interpreters available, we found still the community preferred us to be talking to someone on the provincial line to support them in getting the registered and getting their temporary PHN. Health system, community system navigation, vaccine hesitancy. And this was where we really saw again, like when other community members see their peers in the community coming forward to get a vaccine, it provided them some comfort and also the confidence to come forward and also get it too. For example, we had We had a couple of two Somali women at one of the mosques. And we could tell they were living in the area, but they kind of came to kind of check out what was happening. And they come back again every so often. And then eventually they came forward to get their vaccine. And we've also seen other community members, they got the vaccine at that day. They went out to bring other family members or other friends who had, certain logistical issues or whatever to come forward to get their vaccine. So it was good to see. We addressed the immigration status concerns. We were able to, comfort staff and comfort clients, team members in understanding that for them to come forward for that vaccine, they're not going to be identified and it's not going to impact their immigration status. And it really minimized stress and anxiety. We heard quite a bit from, it was overwhelming for a lot of people to just go through the process. So having a clinic in the community for the community really helped to minimize the stress and anxiety. And we were able to reach some really hard to reach groups or more marginalized or vulnerable or at risk seniors. So although they were eligible for the vaccine early in 2021, many of them chose to get vaccinated at our in-reach clinics that we supported. And so if you think of the time, like from January to April, May onwards, and we were able to support the undocumented migrant workers who came forward who were interested. And in terms of accessibility, we were able to support truck drivers as their work schedule changed quite a bit. They appreciated the walk-in part of a clinic. And again, the mobility issues. And also, I think comfort level too. We had one situation where a parent came forward with her daughter who has autism, and the daughter was only comfortable being at that place of worship and not going to another center or facility. And so we were able to support the child getting vaccinated, but in a modified, adapted way so that the environment was still supportive and safe for her. So just to end with some acknowledgements. Again, our work wouldn't have been possible and successful with all
Sam,
these partners
thanks.
here.
Sorry, I know these are really important people to thank, so I'm going to invite people to look at them on the slide just quickly, and we're going to have to move on to our last presenter.
Yeah.
So thank you very much.
Hi, everyone. Wait for the slide to come up. Good afternoon, everyone. I would respectfully like to acknowledge that I'm joining you today from the traditional and ancestral unceded territory of the Coast Salish peoples, specifically today from the Squamish, Tsleil-Waututh, and Musqueam nations. I ask that you please take a moment to ground yourself and to recognize and reflect on the traditional territories where you're joining us from today. My name is Marion Guenther. I'm the clinical nurse specialist for the FNHA Immunization program. As a healthcare worker, I raise my hands in acknowledgement to the First Nations communities of British Columbia for keeping their territories healthy and strong and allowing us this opportunity to live and work on their lands. I have no conflict of interest to disclose for this presentation. Today, I am going to take you on a journey that highlights some aspects of the whole of community approach for the COVID vaccine rollout in First Nations communities across British Columbia. This approach supports the resiliency and self-determination of Indigenous peoples and improves access to the healthcare by supporting culturally safe practices. Do we have video for this? AP person, can you show the video, please? Thank you.
time to thank all of our presenters for your contributions to this session. We've seen a lot of powerful examples of what we can do and what we should be doing to address racism and achieve racial equity, and hearing about the costs if we do not. I know we're at 3 o'clock now. We are scheduled for a break. I would invite the panelists to stay on for 5 more minutes, and we can have them answer maybe 1 or maybe 2 questions. If anyone needs to go for a break now, please go ahead. We will start again at 3:10. But I'll go to the question for the panelists. So a question around kind of how across our province there's different silos, different organizations working to reach different communities, and are there any plans or recommendations you would have to align the work to reach these populations and communication strategies in particular? I can invite any of the panelists to just put your hand up and go ahead.
Yeah, I can jump in. I think it's really critical to partner with communities on the ground. I think what you've heard from everyone here is that there's a lot of efforts underway. And so finding ways to connect with, to build relationships where there's already trust, so that people aren't swooping in brand new to communities that they maybe don't have established relationships with. I think that's the critical aspect of this.
Thanks, Stephanie. Did anyone else want to comment? Looking at how we can ensure we have a more provincial and sort of coordinated approach to our communications with diverse communities.
It's Marion here too. I think also just recognizing that I know with the First Nations communities, each community is very different, and there's 203 different nations. So it is really important to meet with the leadership in the communities and the people on the ground to make sure that the method that is used and the variety of clinics meet the actual needs there.
Thank you. Would anyone else like to comment? Okay, I think we can, oh, sorry, go ahead. Go ahead, Samantha.
Oh, thanks. I was just going to say, sort of reflecting on it, just if there's a desire across the different health authorities and the provincial level to come together to look at from a diversity perspective, how we could actually start working towards that, that'd be good. Recognizing yes, there's lots of diversity, but how can we do it in more, coordinated way? What I found helpful was, once we started doing our work, we were being connected and contacted by different groups of how can we do this, right? So we're supporting each other. So maybe the conversations start at the provincial level to start and bring us together.
Thanks. Okay, we'll go to one last question. So this is a question directed for Gurvir, someone who noticed that there are, sorry, I'm going to bring up the right screen here. Older generations of South Asian immigrants would carry a significant amount of mistrust with the Indian government, and I think Samantha noted this too, and that this impacted the uptake of vaccines made in India. Can you comment on the relationship between trust in government and vaccine uptake?
The participants that we interviewed, generally there was a sentiment around the community members trusting the government here, and this had to do with the mistrust that the South Asian community has with the government back in India, and just essentially viewing the government in Canada as being more trustworthy and being more attentive to the community's needs. So from what we heard through our interviews, I would say that the distrust that the individuals had with the government in India essentially increased the trust that they had over here, which helped to increase the vaccine uptake within the community.
Thank you. Okay, we're just about at 3:05 here, so we'll call that and have a nice break, and we'll see you all at 5 minutes. Thanks.